Okay. So apologies about the video, but I hope you can hear me clearly. Dr. Paris?
Yes, Lynette, you're very clear. Please proceed.
All right, thank you. Thank you very much for the opportunity, to the organizers for the opportunity to present this work, and good afternoon, ladies and gentlemen. Today we'll thank you for joining the call. Today we'll focus on this topic, highlighting how we can strengthen systems for surveillance and research in Kenya. As I've been introduced already, my name is Lynette Ongeri. I'm a researcher at the Kenya Medical Research Institute, a psychiatrist and also a mental health researcher there. Now, a bit of a background, just the overall goal of trying to focus on systems for surveillance and research in Kenya. We all know right now that really data is gold. And if we don't have a system whereby we capture all this data on suicide and on suicidal behavior, then it's very difficult to actually plan for resources that are need to be put in place. So the idea is to have a very systematic way of filing data regarding either the surveillance and monitoring of suicide and suicidal behavior in the country, as well as research. So I'll just go through what are some of the things or considerations we need to be putting in place so that we can establish a national suicide registry at the end of the day. So again, thank you for your attention. And information to do with suicide always tends to be, it's a heavy topic. And at the end of the day, I'll still share maybe a platform where people can be able to get a linkage to some kind of help if anyone feels like they're being triggered in any way with this presentation. So as Dr. Paris has mentioned, that as a team, we've been working on a suicide prevention strategy that was launched a couple of years ago. And it's what we are really basing on our work here now to look at how to strengthen systems to do with research and to do with suicide surveillance in our country as a way of suicide prevention. So this is something that has already been mentioned in our suicide prevention strategy. And on the left, you can see a link, and that's where you can get the suicide prevention strategy and also go through it. And there's actually something for everyone there to be able to, to see what each of us can do in terms of suicide prevention, according to what has been suggested in the strategy. So I'm part of this National Multisectoral Suicide Prevention Committee, where we're trying to actualize what is within the suicide prevention strategy. So the outline, a brief outline of my presentation today, we'll go through a bit of a background on how the statistics are looking specifically in Kenya and what the gap is as relates to these statistics. Then why should we strengthen suicide surveillance and research systems? Then we look at some of the barriers that exist in trying to establish a surveillance system. And then considerations that WHO provides some considerations to establishing this system. Then conclusion and the next steps. So in terms of our country, as for just similar to many countries in sub-Saharan Africa, Kenya does lack a national suicide registry system, a standard national suicide registry system. And whatever data that we have in terms of number of deaths from suicide are actually estimates. So the World Health Organization models estimates for suicide deaths in countries and also in specific regions. So the data we have is based on the 2019 report, and the report reported that there were about 11 per 100,000 persons who died of suicide within that particular year. And how does this relate to maybe the region and other countries as well? So when you compare it with the global estimates, that's really high. The Kenyan suicide estimate is high at 11 per 100,000 because the global average for age-adjusted suicide rate, it's at 9 per 100,000 population. And 11 per 100,000 is actually similar to what the continents estimate is, age-adjusted suicide estimates is for the continent, for Africa, and Africa is currently the one that is leading with the highest rates at 11 per 100,000 population. And again, just similar to many countries in the world, suicide is higher among males compared to females with a ratio of 3:1. And we know that even if the estimate has been provided at 11 per 100,000 population, it's likely that this estimate is an underestimate. And there are many factors that actually show that that contribute to this underestimation. One is that it's actually a modeled estimate. So it's because we do not have a platform, a national suicide registry system where we're actually collecting this data. So it's an estimate. So that's one. The other thing is really around this existing suicide stigma in the country. So many people fear coming out and really talking about the fact that this individual died, a family member maybe died of suicide. So we may not get the correct estimate or the correct reporting. We did a study some years back, and it was just published last year, and it was on a health demographic system platform. So KEMRI has these mapped out areas within the communities where we look at diseases, that is different morbidities like malaria, like infections, and we also look at mortality. So we looked at what are the causes of mortality and specifically looking at suicide. But we also, for all those mortality deaths, especially the ones related to accidents and suicide, we tried to look at a content analysis. So analyzing what really happened, what are the circumstances. So for the ones that were just reported, yes, the suicide rate seemed almost in keeping with the countries at around 9 per 100,000 population. But when we looked at the content analysis, we found the estimate to be about 14 per 100,000 population. So again, just to emphasize that it's likely the WHO figure is still an underestimate, and it's likely that stigma contributes to this underestimation, and also the lack of a systematic way of collecting this data is also contributing to that underestimate. So why should we be strengthening suicide surveillance and monitoring? What's the benefit of getting all this suicide data? At the end of the day, as I'd said, resources have to really be followed by data. When we provide data, that is when we can be able to plan for resources. So we need to know how big is the problem. We need to be able to quantify the burden, the size of the problem. We need to understand who is most affected. Is it the younger people? Is it the older persons? We need to be able to understand, is it males who are more affected, let's by suicide, or by suicidal behavior, who is more affected? And also the methods that are used, because the methods that are used will be able to inform on suicide prevention strategies. What can we do if it's, for example, pesticides, poisoning seems to be a big problem in the country, then we have to put in interventions that target reducing access to highly lethal pesticides, for example. So this data is actually important to inform the development of targeted suicide prevention strategies, but even beyond that, to allocate necessary resources that can be able to be put into these suicide prevention strategies. Another thing of having a surveillance and monitoring system in place is to be able to also understand suicide trends within a country. Sometimes there are events that happen globally or even within a country. For example, the COVID outbreak, we can be able to understand what was the impact of COVID on suicide trends. Once we have a monitoring system that can be able, to show us the rates, did the rates go up, did the rates go down? And also if we've managed to put perhaps an intervention, let's say it's advocacy, it's creating awareness, then we can be able to see, do the trends of suicide, are they going down based on the interventions that have been put in place? So being able to understand the suicide trends is also important. And that can only happen if we have a surveillance and monitoring system in place. Generally, globally, but mostly, especially in low and middle income countries, especially, for example, Kenya, we do have very scanty knowledge of suicides in terms of numbers, in terms of other, risk factors for suicide. And one of the bigger reasons of why we have scanty knowledge is the fact that a lot of this data tends to be fragmented in the way it's reported. So it's reported in various registration systems, and we look at these various systems, and it tends to be fragmented. So again, pushing for a need to integrate all these various systems to be able to get data that is actually useful to put in interventions. The other, aside from just the data being fragmented, is also the fact that it's sometimes with suicide or with self-harm, it's actually difficult to be able to be 100% sure of the intentionality. Did the person actually, was the plan to actually die, or was it an accident, or was it an homicide? And a lot of the time you find suicide cases are being reported as accidents or homicide, because that intentionality sometimes is difficult to distinguish. And then even with the fact that we've mentioned that there are various platforms that are recording on mortality, and maybe even now, in this case, suicide mortality, the problem also is that the data is not extremely comprehensive. We have partial data. A lot of the platforms that may have this kind of data may be missing data or information on the method that is used. And as I mentioned before, method is really important for us to be able to put in interventions that target specific methods. So overall, there is a need to establish these systematic registration practices for suicide and also for suicide behavior. So aside from what we've just talked about, the issues around the fragmented nature, the difficulties in distinguishing if it was the intention or self-harm, and also the fact that the data is not extremely comprehensive, there are other universal factors as well that are a barrier to suicide surveillance. And this is really focusing on the reporting itself. The first one is the suicide stigma that I had alluded to in the beginning. We know in Africa, in Kenya, suicide is really a taboo subject. Many people don't even want to say the word, and we don't even have we lack like an indigenous or our own ethnic language to actually describe it, because it's such a taboo subject. So people would have a lot of fear reporting that maybe their loved one has died from suicide, and it will be reported as something else because of all the cultural stigma that is in place. And there's also religious stigma, because also most religious denominations or organizations are they have a lot of stigma that is riding around issues to do with suicide. And then in our country right now, suicide is decriminalized. We've been pushing a lot of efforts around, suicide is criminalized, apologies for that. We've been making a lot of efforts to decriminalize suicide. And the fact that the law is, speaking on criminalization of suicide makes people not be able to actually open up and say this is what actually happened, again because of that fear of the stigma associated with suicide. So the criminal nature of suicide just increases the aspects on suicide stigma. So aside from the stigma that is existing, there's also the constraints around resources. Resources have to be allocated for a team to be put in a formal suicide registry system. And resources can be in terms of human resource, and even the existing human resource really needs to be trained on that systematic way of capturing data related to suicide and related to suicidal behavior. So there's need for that investment, and also investment on the platform itself, so that there's good data management of the reports that are coming in on suicide. We can make sense of them in terms of analysis. We can make sense of them in terms of reports, and even to tailor the reports in a way that is useful for different people, be it policymakers, be it health professionals. There is a need to invest in that data management system. So the WHO puts across some considerations. There are about 4 considerations that we should be thinking about when we're thinking about establishing a suicide registration system. The first aspect is really around how will we be able to identify and also certify that the deaths are actually from suicide. The other aspect is to be considered is on what information needs to be entered in case registration form specific to suicide. Who shall be involved in the data collection is a third consideration. And the last consideration is how will the data collected on suicide mortality be utilized? Because if you collect data and it just sits somewhere in a repository or in a database without it being utilized, even the persons who are collecting the data, maybe at community level, at county level, will not really feel the need or the significance to keep doing it, or to keep doing it at the level that they're doing it at. So the data has to be utilized. So at the end of the day, we need to focus on these considerations when we are thinking of setting up the suicide registration system. So now I'll take you through each of these. We see what the team has been discussing in terms of all these considerations. So the first one is around identification and certification of suicide deaths. So here again, we really follow what has been suggested by the World Health Organization, but also what is feasible and acceptable or sustainable in our setting. In terms of our specific setting, Kenya is lucky that we do have a good civil registration system. So all deaths, all births are usually recorded at the civil registry system, at the civil registry. And the important thing that this mortality data, all cause mortality data, is recorded, and it's countrywide, it's compulsory, and it's routine. So the data is sitting on all mortality now, including suicide, is sitting at the civil registry, at our civil registry. And so based on that fact, it's ideal really as a primary source of this national suicide data. The only catch is that this information tends to be quite scanty. So there is a need to be able to integrate whatever data we are getting from the civil registry with other agencies to be able to integrate and link and get more information so that we can be able to analyze and make sense of the data and utilize that data in a more useful manner. The other thing is also that it's a lot of the data comes in paper format, so we have to actually digitize a lot of these systems. I think the country is really moving towards digitization, so that's also a bit of a challenge right now. What is being shown down there is it's a template of what really is captured when it comes to any death with the civil registry system. There's the name of the deceased, there's the ID number, there's the date, there's sex, age, marital status, the place of death, the type of place, usual residence, and the cause of death. So these aspects are actually captured within their systems. And maybe what is even more important, there are certain indicators here that are really important with suicide, but also aspects of the ID number will allow us to do some level of linkages and integration from other systems. So what are these other systems that we can also integrate or link up the data with, so that we can get a more comprehensive picture of what really happened with the specific individual. The other agency or the other platform that we can use is the mortuary records. So mortuary records, we've gone there, we've done a bit of just reviewing the kind of data that is available and specific to suicide. Here we were focusing a lot more with city mortuary, and we looked at, they have different points of data entry. At the immediate entry, the first entry level is at admission. There's an admission book record. And at this level, it's usually captured by police officers who are linked to the mortuary. In this case, for city mortuary, if it's a hospital mortuary, the health records officer who put down the information. And here for city mortuary, because it starts off with the police at most of the time, the cause of death can actually be in as suicide. But then for all suicide deaths, they have to go through a postmortem report to confirm that. And usually the PM book the postmortem report will not really mention anything to do with suicide. They would probably mention things like asphyxia secondary to neck compression, organophosphate poisoning. So we have to find a way of being able to capture even the different terminologies, because when someone goes there to send out this information, it will probably not be captured just as suicide based on the PM book, on the postmortem book. So again, here it's important to work with different agencies. we've been working and talking, some of our members actually belong to the forensic and pathology services. So it's important to work with the Division of Forensic and Pathology Services at the Ministry of Health to be able to coordinate, be it the training and be it the transmission of data from the community level to county level to up to the national level, trying to be able to transmit this kind of data. Again, integrating it in with what we found with the civil registry systems. And another thing about the mortuary records, a lot of them was still having paper-based records. So again, digitization would be very helpful to be able to do this transmission and coordination and transmission of data at the end of the day. Then the other avenue or the other agencies that would have mortality data specifically on suicide is the police records. Some members of our teams have started looking at various police records to look at what kind of data is actually captured. And it's interesting that police records tend to capture a very detailed report on circumstances around the suicide. And these circumstances are really helpful in informing even prevention measures. So it's extremely detailed. It increases our understanding of what really is happening because they have to really spell it out, what really happened in specific circumstances. Now, the other issue, though, is that at the level of the police records, the PM has not really been done at that point. So it's really just the circumstances of what had happened. So the postmortem are not really linked. Then there's the aspect that a lot of the police records, again, tend to be paper format, and there's need to have a more of a centralized system. I know they're working on this, and they're already having representation from the police to be able to see if we can get more centralized data and still detailed in its format, specific to suicide. So we've managed to reach out to some of the police leadership, provide this kind of data and see how we can integrate it into a national suicide registry system. So according to the World Health Organization, they give us a report on what are these parameters, what is this kind of information that needs to be recorded when someone is coming up with a national suicide registry system or a suicide case registration. There are some basic information, for example, the age of the individual, the sex of the individual, the method of suicide, and this is based on ICD-11 codes, the date, the time of suicide, location where someone was found, the place of residence, if there was an existing suicide note, and also a statement indicating the intention to die. So these are some basic information. As you can see from what I had shared from the civil registry, a lot of this may not even be present. Some of this information is there, like the age and the sex, and the place of residence is actually there. So there's that need to triangulate maybe with the information from the police records to really understand, was there a suicide note, was there an intention to die, and things like that, to be able to fit in that kind of information. So integration and linkages of the data is really critical. Additional information also that has been suggested by the WHO to collect when in a registry format would be information that preceding the circumstances that are related to the death. For example, was there a history of alcohol and drug use? That has been shown to be one of the larger risk or bigger risk factors for suicide. Then there's history of mental or physical illness, another huge risk factor for suicide. Recent adverse life event, it's something traumatic really happened, or an adverse thing that happened. For example, losing a job and things like that. Just preceding the death, marital status, employment status, occupation status, and ethnicity. So again, this makes the data a lot more richer, and the additional information is helpful to be able to tailor-make interventions specific to maybe if it's something to do with substance use, can we tailor-make interventions for persons who are going through maybe rehabilitation or who have problems with substance use. So the information around the death is also just as important as the death happened because and the death is a suicide. So this additional information can be obtained from the police reports as I'd mentioned. Some of the information can also be obtained from medical records, for example, the history of mental or physical illnesses. And the information can also be obtained from psychological autopsy. Psychological autopsy is really in-depth understanding of maybe we reach out to the relatives and of course with a lot of support, because this can be triggering, and ask them the circumstances around. And it's really, really rich data. It's very informative and really helps with planning for interventions specific to suicide prevention. Okay, the other aspect was who would be involved in suicide data collection. They are persons who are directly, linked and very resourceful, would be very resourceful. All these persons would really need to take them through training on now the parameters that we are looking for. And some of these are the medical officers who interact with patients, the pathologists who are conducting the postmortems, the mortuary attendants, the mental health and health workers. We've seen mental health conditions are a big risk factor. The police, health information systems, staff and statistics officers, researchers who, for example, we talked about the health demographic systems, for example, KEMRI. So these researchers who are researching in this field of suicide can also provide this kind of data. And then relevant NGOs and community-based organizations that are working in the suicide space can also be a huge resource and may need to be trained on that systematic parameters or information that we require in our database for the suicide registry. So in terms of utilization, what do we do with the data? How do we use the data that has already been collected and is sitting at the suicide registry? It's extremely important that the data, maybe in form of reports, analyzed data in form of reports is shared to policymakers, because they're the ones who will, push forward policies that are specific or that are targeted for suicide prevention based on what the data is actually saying. So the data needs to be shared on a more regular basis to policymakers. The data needs to be, people need to have access, especially researchers need to have access of maybe the identified data to be able to run a lot more analysis, even modeling analysis, to be able to inform a lot more on what the burden is, what are the determinants, and in terms of interventions, what is also working. So having researchers have access to the identified data is extremely important as well. This information also needs to be shared with health professionals, because they are the point of contact. They'll be able to understand what are the risk factors, who should they even be focusing a lot more on, what interventions seem to be working based on the way the data is coming out on trends. So health professionals are really key as partners in being able to get this information. So at the end of the day, by sharing this data, we allow a greater exposure to the problem of suicide. And as I mentioned before, the more we expose the problem, the more targeted resources are put in to be able to address the problem, to be able to reduce suicide at the end of the day. It's raising awareness. Raising awareness reduces the stigma that is already attached to it that I mentioned. Being able to see where the gaps are. When we have this data collected, when we share the data, we can see where are the gaps, and researchers can be able to develop proposals that are addressing these specific research gaps that are coming out from the data. It also helps us in developing prevention campaigns and monitoring how effective certain strategies that we've already been putting in place, how effective are they, how are they working in the community. So aside from just completed suicide, I've just been focusing a lot more on completed suicide. It's not enough to just look at suicide as suicide deaths only. It's also important to bring in the aspect of surveillance of suicidal behavior. In this case, we are really referring to suicidal attempts. So suicidal attempts managed a lot more in our healthcare facilities, and they present a lot more as maybe pesticide poisoning, as cutting and stabbing, as drug overdose. Those ones, they present a lot more in our healthcare facilities. And this data is also extremely important, because when you're looking at it from a preventive perspective, we can be able to put in interventions for for preventing suicidal attempts as well. And there's a need to be able to capture this data in a more comprehensive manner, perhaps within the Kenya Health Information System. So right now the discussions are, how do we capture suicidal attempts from, let's say, all the public hospitals, just the way we capture data on malaria, the way we capture death data on maybe maternal mortality. How can we capture data on suicidal attempts in our Kenya Health Information System, or the KDHS that we used to have, that formerly known as, yeah. So from our health information system, we are currently piloting ongoing. There's an ongoing pilot going on, ongoing pilot in a number of facilities, I think more than 10 facilities within the country. And one of the indicators, aside from other mental health conditions like depression, like substance use problem, one of the indicators is also suicidal attempts. So we hope once the pilot is successful, we can be able to learn from the pilot and be able to scale up this reporting of mental health conditions, and one of the conditions actually being suicidal attempts. One of the measures, one of the indicators being suicidal attempts. So this data, when it's reportable, will be collated at county level and forwarded to the Ministry of Health at the Division of Mental Health, specifically to look at suicidal behavior and to look at trends for suicidal behavior. So again, the topic was around suicide, to monitoring, surveillance and monitoring, but also there's a research aspect. So we called the surveillance and the research actually go a lot hand in hand, and they are interlinked in very many ways. Research is extremely key in understanding the risk factors, in understanding protective factors, so that at the end of the day, we can prevent suicide, and in what is relevant actually to the Kenyan settings. Use interventions that are relevant for the Kenyan settings based on the information we're getting from risk factors and protective factors. So in terms of research, there's already a lot of research that is going on or has happened that has looked at prevalence, at distribution, at patterns, at risk factors and protective factors. Of course, we still need more research in this aspect, but already a lot has been going on. And this research, of course, it's very useful at policy level, at advocacy level. For example, the way we've been saying we're trying to advocate for decriminalization of suicide. By having this data from research on prevalence, on the burden, how many people are actually affected, let's say of suicidal attempts, how many people are affected, it can really help with our advocacy efforts in decriminalization of suicide in our country. So in terms of resource planning, again, I'll keep repeating that you can't really allocate resources if you don't know the magnitude of the problem. So research is really, really critical. The beauty about research also that goes beyond just surveillance and monitoring is that we set up indicators that are specific to our research questions. So it can be a lot more in-depth in the way it's we collect our information, and it can be a lot more targeted in the way we collect the information, depending on what the research question is. So again, it goes hand in hand with surveillance and monitoring, but it's also key that we provide for research in suicide and suicidal behavior studies. We can also have research in interventions, trying to see how preventive interventions that have been put in place, are they effective? How are they working? Are they acceptable? Are they feasible? Are they sustainable in our settings, both for preventive measures and also for care measures? These are very important in health promotion, in therapeutic interventions for preventive measures. It's really important information. And as I've mentioned, we know that already there's a lot of research that has been carried out in this area, not as much as what we would really want, but to be able to understand, so what are the gaps? It's important to carry out things like scoping reviews or systematic reviews. So it's trying to get the summary of the evidence on prevalence, for example, the burden, to get a summary of the effectiveness of preventive measures that have been put in place, or effectiveness of the care measures that have been put in place. It's important to carry out scoping or systematic reviews to get these summary reports. One, it'll be useful in just collating that information as in general to see what was the burden like, This informs a lot of policy work. It involves a lot of resource allocation. But even beyond that, we're able to see the gaps. So what is missing? We know that there's been research, perhaps it's been conducted only in, let's say, the coast region. Has there been any research conducted in maybe the northern frontier of Kenya? What is really happening there? So by carrying out these scoping reviews, we are able to really see where the gaps and what should we put in more resources when it comes to either defining the burden or defining preventive measures that are working. So scoping reviews and systematic reviews are really important. And we've been, again, with the team, the technical working group, we are just planning to undertake a scoping review of the research that has been undertaken in Kenya around suicide and suicidal behavior. So in summary, when it comes to surveillance and research proposed, there's that aspect of surveillance and there's also the aspect of research. When you look at surveillance, there's the aspect of suicidal deaths and also of suicidal attempts, not just the deaths. And for the deaths, there are various death records where we can look from civil registry systems, from police records, and also from psychological autopsy, where we interview more detailed interviews of the deceased relatives, to just ask them a little bit more about the circumstances. Then around suicidal behavior, we've talked about the health information system. If we make suicidal behavior a reportable incident, then at the end of the day, we can collate this information from county till national level. And that would be an easier way to set up this surveillance system. Then in terms of research, we talked about we already have mapped out areas. So these mapped out areas, they do a lot of reporting on mortality, maybe from malaria, from HIV, from all these other diseases. So why not also specifically look at suicides? Already we have 3 mapped out areas that have already reported on suicide. In Kombewa, that is Western Kenya, in Kilifi. We also have one in Ahero that also reported on this. So it's important to keep looking at the community surveys and see what is the pattern of deaths, what is the burden of deaths, and what can be done in terms of preventive measures in these areas. At a national level, we are currently planning to do a national mental health survey. And part of the mental health survey, one of the indicators we're looking for is suicidal attempts, history of suicidal attempt, and also suicidal plans and thoughts or ideation. So this is in place. I think we are right. We are just gathering the resources to undertake the research, although now the ethical approvals are already on, we already have ethical approval. So it's just gathering the resources to do a national level adult population survey, mental health survey. We already have for adolescents. Now we want to look at the adults as well. And also retrospective facility-based records would be important from a research perspective. So we need to look at how we can improve the availability of suicide data. Again, I've mentioned that it's a collaborative process. And it's a synthesized process where we synthesize from hospital mortuary records, we synthesize from mortuary records, we synthesize from civil registry, and also from police records. So it's going to be a very coordinated affair to be able to get comprehensive suicide data. And again, one of the ways that we are pushing is to be able to make suicide and suicidal attempts a reportable health indicator. Again, for us to get quality data, for us to make it reportable and get quality actual data on this, there's that aspect of the stigma, and there's the aspect of legalities of suicide. Yeah, so improving the quality of the suicide data itself, there's training that really needs to go into place for all the people who I've mentioned who would be concerned with this kind of data. We train them on how to report the parameters we've just discussed accurately, consistently, and comprehensively. And also looking at the law, because a lot of people fear really saying what exactly happened because of that stigma, and also the repercussions itself. When it comes to suicidal attempts, because it's criminalized, you'll find that even healthcare workers would report something else rather than that it was a suicidal attempt. Maybe they would report it was depression or substance use rather than reporting on that, because there's actually a lot of implication based on where the law is standing right now. So again, there's a lot that has been happening in repealing the law. There was a case petition to decriminalize. But beyond this, many people still think that the law being in place is a deterrent. But we know from other countries that have decriminalized suicide that it's actually useful. It has been shown to be helpful in preventing suicides, because people are actually able to come out and say, I'm having these thoughts, I need help, how can I get help? And setting up structures that can help people who are having suicidal ideation and are attempting suicide. So we need to increase mental health literacy on how decriminalization works, that it's not saying that we want to make suicide okay. We just want people to be able to access care a lot more easily, because and recognizing that suicide is really more of a health issue rather than something to do with the law. And a lot of advocacy still is going on and needs to continue going on. So in terms of data analysis, just to reiterate that the data is important for understanding patterns, trends, and risk factors, and that in-depth understanding from psychological autopsy is really key. So in conclusion, we as a team, we're trying to source funds to establish this comprehensive and standardized system, collecting data on suicide and suicidal attempts. The parameters or the information we are really going to be focusing on is around the demographic information like age, like sex, occupation, marital status, location of the suicide. We'll be also looking at the method of suicide, because again, this is really important in putting in measures for prevention. We'll be looking at time trends and also contextual factors, especially from the psychological autopsies. Again, to reiterate, it's a collaborative effort with the various agencies, be it the police, be it the Ministry of Internal Affairs, from the civil registry system, the police, to the mortuaries. So various agencies have to be involved. And then the integration needs to happen at the national MOH platform level. This will allow for ownership and also sustained reporting. And overall, to really narrow in on the quality, to ensure the quality of data is good, that we are capturing all suicides in the country, we really need to think about the suicide legal status, overall suicide legal status. As I said, this information can tend to be very triggering. So it's if anyone is feeling, affected in any way, we have Befriend Us Kenya. It's one of the NGOs that we work closely with, because they're able to provide even immediate kind of care through this line. It's not free of service, but at least they're able, if you call in using that line, they're able to provide care to you. And their website is as stated there. Thank you so much for your attention.
Excellent. Thank you very much, Dr. Lynette Ongeri, for the very detailed and informative presentation that you have given us this afternoon. I'm going through the chat to see if there are questions, and I have seen one question on, the question is there an attempt by MOH to help victims of suicidal attempt from being regarded as criminals? Dr. Ongeri?
Yes. In fact, this is what I kept emphasizing. Even within the National Suicide Prevention Strategy, I think there's a whole chapter around suicide decriminalization. Part of the National Mental Health Task Force, in their report, also, I was a member of that team, we really emphasized on the need to decriminalize suicide. So again, there's lots of efforts that are going here, from petitions at parliament level to repeal the law. There's case petitions to the Attorney General Office to repeal the law. There's a lot of advocacy webinars that are going on about decriminalization. But I think the reason why we're having even these discussions for today's meeting is about understanding the burden. These policymakers, if we're able to share with them the burden, like this is what is going on in our country, at the end of the day, data really speaks a lot. They can be able to see this is actually a health problem, and instead of trying to criminalize it, we need to increase access to care. We need to help people who attempted suicide get the required care that they actually need. So having a surveillance monitoring system is also really critical in being able to push a case for decriminalization of suicide. Thank you.
Thank you very much, Dr. Ongeri. There's a note here for data collection on suicide attempts. Let it include all health workers that are likely to come into contact with the survivors, including community health.
Pardon, I think I missed the question. Go, please repeat, Paris.
Sorry, my network got a little unstable. So the concern was about, I don't know whether you got it, Dr. Lynette, you can respond to that.
No, please repeat the question.
It was actually a comment. Let me go back to it. That I read it as it came.
Mm-hmm.
Yeah, for data collection on suicide attempts, let it
Mm-hmm.
include all health workers that are likely to come into contact with the survivors, including community health volunteers. Maybe you can comment on that?
Yes. I think that is really critical. And initially, when we were starting to think of this registry system, we were thinking, okay, which is the easiest to actually, implement in terms of the Kenya Health Information System. We already know it's in place, and we already know that there are certain conditions that are already being reported. So it's the Kenya Health Information System is still linked to the community at the community level. So it's something that we are pushing, whereby we'll say we'll make suicidal attempts, will make suicide be a reportable incident or a reportable indicator. So from the level of the community to the level of health facilities, that is still going to be captured. That is really the plan. But I know transmission of the records happen from the facility, but this information system is still plugged in. It's still linked to community at the community level. Yeah, thank you.
Yeah, thank you, Doc. There's another question. How do you help a teenager who has attempted suicide twice and doesn't want to open up?
Okay, so I think, again, this is, it's important that the person really has access to good quality care. And there are very many specialists who are able to, to be able to offer the care, specialized care in trying to support the individual. And suicide and suicidal attempts, it's a really complex issue. So it means that there's need to be able to sit down with the individual, to be able to talk to them even at the family level, to be able to just try and listen and understand and show them that you really, you understand what they're going through, that they must be going through a lot. So that empathy is really critical, even at the family level, that it's not easy for someone to, make that decision that I'm going to, to attempt suicide. It's a difficult decision. And this means that this person is under a lot of psychological distress to be able to reach that conclusion. So being able to provide that empathy in a situation whereby the person might be feeling hopeless is critical even at home or with the relatives and the family members at the family level. But then even beyond that, being able to say that, you know what, I can still link you to care. I can take the specialist who can be able to help. And again, it's not something that it's just a one-time thing and it's done. There's need for continued care. So even if maybe someone has received care once, it's important that the care is more of continued, so that it can really be addressed as to what really the issue is. But please, let's not just give up on our family members, on our loved ones. Let's just keep reiterating that we care, we understand, and will continue supporting you in this, in the way you're feeling, and we'll keep linking you to care. That support system is extremely important. Thank you.
Yeah, thank you very much, Doc. I can see a lot of comments on telling you that was a very great presentation, and there's also a question, or rather a request for you to expand on psychological autopsy. Do you offer psychological management to relatives? That's a question. When you do psychological autopsy, do you go ahead then to offer psychological management?
Yes, yes. And that's a very critical question, and it's a critical area, because the persons who've been bereaved from suicide, it's likely that they would actually need a lot of support based on how tragic a death the suicide can be, and also the fact that they're also in grief, just the fact that it's actually a death, and also the stigmatizing factors that are all around them at that particular time. So yes, during psychological autopsy, psychological autopsy has to be done by someone who's actually trained to be able to undertake psychological autopsy, because we have to be careful in how we bring up the questions, in how we are able to support the individual, in being able to pause at every point. But also for all psychological autopsy is that linkage to care. So it's not enough to just give someone maybe a sort of first aid, or once they open or share anything. It's important that they are linked to care, because again, it's important to have more continued care. It's unlikely that the care will just be a one-time thing. It's important that the care is continued, so that the person feels supported, even when later on, when they're going down because of certain triggers in their lives, they're able to still go back for that sustained care. They're able to access that sustained care, and they're able to get help. So supporting the bereaved during psychological autopsy is paramount during that autopsy itself, but also linking them to care beyond the autopsy period. Yeah, thank you.
All right, thank you very much, Doc. I can see there are people who had raised their hands. I don't know whether they are able to unmute and speak, but I would suggest it would be best if you put your questions in the chat. That way we are able to answer them either through this session, or even they can be addressed later. We'll appreciate that. There's another question. What was the initial reason for criminalization of suicide in Kenya?
Okay, so this is the law that we inherited from the British. We were colonized by the British, and initially the law is, we inherited many laws. For a long time, we've been scrutinizing these laws and repealing them. And there are very many countries that have also ended up inheriting the same laws, but they were able to actually scrutinize and see, are these laws even working for us, and be able to repeal them. And even the people who we inherited the law from, who were the British, they already decriminalized suicide in their country. So most high-income countries have decriminalized suicide, and because it's really seen as a health issue, and the victim really needs to be linked up to healthcare rather than to be taken to jail or to courts, and even adding more injury to the distress that they already have. So this was something that was just inherited as part of the laws that we inherited from the Brits. Recently, Ghana is a country that is so similar to Kenya, managed to repeal the same law, and it was a journey, but they managed to actually repeal the law. So in Ghana, the suicide is no longer criminalized there, and I feel like we are really heading there, especially based on the efforts we've been putting in place. Thank you.
Yeah, thank you very much.
And maybe Paris, Dr. Paris, maybe I would add that many people still feel like it's deterrent it deters people from attempting suicide. The law being in place deters people from attempting suicide, but studies have actually shown that it really doesn't. And what it does, it pushes people even more to do it and be, end up even dying of suicide because they're trying to not end up in courts or in jail. So there are studies that have actually shown it's not a deterrent, it's actually something that worsens the situation for someone who's already having suicidal thoughts and is having suicidal plans. The law being in place is not really a suitable deterrent. What needs to be in place is access to care, specialized care that can be able to assist these people and reduce stigma so that they can be able to seek out this care that they need. Thank you.
Oh, wonderful. We do have another question, and the participant is asking, do we have data for suicidal cases from health workers?
Okay, so that's not very clear. Is it as health workers being victims of suicide, or is it health workers being able to share data on the numbers of suicide that have happened in their facilities? It's not super clear, but I think what we have in terms of data is really based on research platforms. So who are carrying out research in health facilities, probably at, let's say it's a general hospital level. They will go to a particular hospital and interview everyone and see among those ones how many have attempted suicide, how many are having suicidal thoughts or suicidal ideation. So that has been what has really been the focus. And even at community levels, we've collected data on suicide. So it really has been from a research perspective. But what we are pushing for, let it not just be research, let it also be based on surveillance and monitoring. In terms of looking at suicidal thoughts among healthcare providers, yes, especially during COVID, there were lots of studies that were looking at the well-being of healthcare workers, and some of the parameters that were captured were around suicidality and suicidal ideation. And because of the trauma that healthcare workers, the kind of environment the healthcare workers go through, they do have a lot of stress, they do suffer a lot of burnout, and there are higher levels of even the suicidal ideation. So there's really a big gap in terms of trying to support healthcare workers. I know a lot was put in during COVID, and I hope we continue to support healthcare workers so that they are able to open up and talk about what they're going through and they feel supported. Thank you.
Yeah, thank you very much, Doc, for the very comprehensive responses. There's another question. Have you tried to explore the spiritual angle of suicide? I would want to engage more. That's from one of the participants.
Okay, so that spiritual angle is not to be taken lightly. It's a very important angle. And the reason why, it's because we found out from a lot of research that we've been carrying out is that most people actually see suicide as a spiritual matter. So we can't say that, oh, we will only take care of the ones who end up in the facilities. Many people still go to religious leaders to be able to get support because they're having suicidal ideation, because they're having suicidal thoughts. And what is really key is being able to work collaboratively with religious leaders to be able to really to show them, to through what really are drivers of these suicidal attempts, what are the drivers of suicide in the population, why would someone end up in this particular state? It's not, something to do with, something like they're evil or anything like that. Yes, prayers are important, but it could be that the person has a particular psychological issue that needs to be addressed, a mental health condition that needs to be addressed, or just psychological distress of a life event that has happened to the individual at that particular moment. So being able to take religious leaders through what suicidality is really all about, and also being able to take them through small, easier interventions. What can they do to support persons who come to them who are suicidal. What can they do? What are the interventions? Maybe short, brief interventions that they can actually undertake. So this is also part of our suicide prevention strategy. We look at religious leaders as gatekeepers, and we really are looking into working very closely with religious leaders. And more importantly, for religious leaders to know at what point should they be linking these patients or these persons with suicidal ideation or suicidal plans. At what point should they be linking them to healthcare through the healthcare system for specialized care? So it's a very collaborative effort. We will not say that we're not, linking with them, and we look forward to really working with religious leaders. Thank you.
Thank you, Doc. There's another question. How can I get helpful and proven information on how to deal with, I think it's attempted cases of suicide. So how can somebody get that information?
I think you can just reach out to us so that we are sure about like what exactly you need. There's already that the National Suicide Prevention strategy that we've shared. We've shared the link. It's available on the MOH platform. If you just Google that, you can be able to see what's been happening. But if you reach out to me, reach out to Dr. Wambui, we can be more specific on what your needs are, and we can be able to even assist you. But a lot of the information is actually captured there. And there's also the National Mental Health Task Force report. We also give a lot, I think there's almost a chapter around suicide prevention and what needs to happen. So those aspects are there. And we work together with a number of NGOs, including Befriend Us Kenya, that offer a lot of interventions at community level. So we are trying to really expand the space that is able to address suicide in our communities and also in our country. Yeah, thank you.
Yeah, thank you, Doc. There's another question. Someone is asking, does suicide run in families?
Well, yes, to some extent, yes, but I would really emphasize that the environmental factors are a lot more stronger than even the maybe genetic factors. There's a lot of research that is going on to try and understand, are there certain gene variants that are more associated with suicide, with completed suicide, or with suicidal behavior? Is there something specific in terms of genetic makeup? And also, and maybe that's what would be informing why you find, because genes are inherited. So that's why you'd find like, someone aside from maybe someone dying of suicide, there's also another person who died of suicide. But even beyond the genetics, the contribution of genetics is it's very, very small. But beyond the genetics, there's also the aspect of the environment itself. So people who are, victims of suicide, the burden that is left with the family is really huge. And the bereaved persons are really at risk, and they need a lot of support. This just dealing with the death that happened, that is because of suicide. They really do need a lot of support. So being able to get that support is extremely critical. So I feel like the environmental factors are they're even a lot heavier than the genetics part of it. So to just say it runs in families, I don't think it's enough. We really need to look at the environmental factors. For these persons who've been bereaved, is there a system that can really support bereaved persons so that they can always feel supported, not feel stigmatized or discriminated because their loved one died of suicide? Being able to have a platform where they can talk and even have some sort of peer support groups for persons who've bereaved. They can lean on also on each other and aspects like that. So there are interventions, and these interventions need to be targeted for bereaved persons, but a supportive environment is extremely key, even beyond the aspects of, genetics. specific to suicide. Thank you.
Yeah, thank you, Doc. There's a question. Is there any plan to prevent suicide amongst the teenagers and students?
Yes, that is a really big area right now, because we are actually seeing, the trend is there's actually a lot of the higher suicide burden is within that age group. And a lot has been done and continues to be done, especially sensitizing teachers on what are the signs, what should they be looking for, and how to support teenagers. I think the biggest thing around teenagers and young persons is really to put in structures that support their mental well-being, not so much specific to just suicide, but in their mental well-being. Do they have platforms where they're able to share, to talk about what they're feeling? If they're feeling depressed, is there someone there to be able to support them? So already, I know the education system has been working a lot more with the Ministry of Health to put in counselors, put in measures for students getting counseling, and to put in measures that help support the mental well-being of students. So just being able to support their mental well-being does a lot in terms of preventing suicide at the end of the day. But as a country, again, we need to be able to not still put it as a taboo subject. If children are, reaching out and they want to talk about suicide, we can't, say it's a taboo. We can't talk about it and things like that. We have to be open enough to talk about it, because if they're feeling, and there's a myth that when you talk about it, you're making the person now attempt. That's just a myth. It's not true. When it's being voiced and you're able to talk about it, the person actually feels, okay, at least someone wants to listen, someone wants to hear me, and you're able to be able to get them to care. You're able to find someone who can be able to assist them. So talking about it is actually a very big part of suicide prevention. And especially for our youth, we have to be able to open up and have supportive environments that they can feel that they can share if they're having suicidal thoughts and suicidal plans. Back to you, Dr. Paris.
Yeah, thank you very much, Doc. Someone is asking if there are any safe spaces for suicidal survivors.
Yes, so a number of these NGOs do have the safe spaces. I know, for example, what I'd shared, the Befrienders Kenya have a group support system. And if you reach out to them, they can be able to link you with information where they can get how you can join a support system. But even beyond that, it's also up to us as individuals. We can also create our own safe spaces. If you need support from the Ministry of Health, I'm sure we can find someone who can be able to steer it, to help with finding maybe someone who can give the technical advice. But creating the safe space is really by people who have had that lived experience and they're able to support each other. So even you as an individual, you can think of starting something like that, but gaining some technical advice from the Ministry of Health. There are also private institutions like Chiromo also has Survivor Safe Space, where they are able to share. So if you reach out to those organizations, and I think also, and Red Cross also is another, they have a call-in center that allows people to call in and reach out. So there are resources. I think part of the previous talks were really focused on these resources that exist. And maybe we can share with the team regarding just the resources that exist. I feel like that is also a discussion that is big enough to be had in another webinar series. Dr. Paris, what do you think?
Yeah, indeed. I think that is something we are working on. I think after this series of suicide prevention webinars, we are going to have another one for mental health series. So I think we'll be able to share a lot of this information in those sessions. Thank
Okay.
you. So there's another question, though it's not very clear. What is the difference of suicide and depression from medical reports? Maybe Enoch, you can elaborate on that question even more so that then it's clear to us. I don't know whether Dr. Ongeri, you have understood it.
The difference between suicide and depression?
Yeah, from medical reports.
From medical reports, I think maybe he's referring to what I had mentioned, that because suicide is now criminalized, some healthcare workers might be a bit hesitant to put in that maybe this patient came in with suicidal attempts, because at the end of the day, now that becomes now a criminal issue. But at the background of suicidal attempts, it's likely that the patient might be having depression. Yeah. So what is actually put in the report, the medical report, is that the patient has depression. So it's not really indicated that the person came in with actually suicidal attempt. But from a perspective of us trying to look at surveillance and data and good quality data, accurate data, then we would be missing on the burden of suicidal attempts. We'd only be getting information on depression in this case. So it's the decriminalization efforts. It's also to ensure that this data is accurate enough so that even healthcare workers can indicate, yes, there was depression, there was suicidal attempts. This person came in maybe with substance abuse and they had attempted suicide. So that's, I think, the link there. And indeed, persons who attempt suicide, a big number of them, even closer to 90%, have a diagnosable mental health condition. Be it depression, be it substance use problems, or traumatic events that have happened to them. There is something diagnosable. So they do need a lot of mental health support. Yeah, that's what I can say. Thank you, Dr. Paris.
Yeah. Thank you, Doc. Thank you very much. So I can see one of the participants had raised their hand. Kindly, I'm suggesting we use the chat facility so that we're able to get all the questions there because of some technicalities of unmuting and starting to speak. So there's another question on, can we count the health workers who gave wrong medications to patients, which later caused them to cause adverse events and even death to be counted as suicides?
Okay, that's not very clear. Just repeat the question.
It's a case of a healthcare worker who gives the patient some medications that cause adverse events and later even death. So can that be considered as suicide?
No, that's not suicide. So because the idea is really about what the definition is, intent for self-harm. So it's the individual themselves who intentionally, or I don't even know if the word intentionally can be a bit biased, but the intent to die was actually from the victim themselves. So it wasn't, because the way you described it, it's like the healthcare worker may have given medication, but the victim did not have any intent to die. If I'm getting that correctly.
People are, yeah. Thank you, Doc. So people are asking for the slides. Yes, we are going to share the slides. There's a question, why the high rates of suicide rates with male? Any specific contributing factor?
Okay. Yeah, there are studies that have tried to understand why the rates are higher in males, and there are various factors. It's not just maybe one thing. It's more of a contribution of various factors. One of the things that with the males, when you compare males' health-seeking behavior compared to women, we see it's different. That women tend to seek care a lot more compared to males, even being able to open up about maybe the fact that they're in psychological distress. They are experiencing some level of distress. They are thinking about suicide. They are planning. Women are more able to seek out help when it comes to that health-seeking behavior compared to men. And that is one of the differences. The other difference that has been shown from studies is that intent to die. You find that women would tend to use maybe less lethal means compared to men. Men would tend to use very lethal means. And so the chances that they would die of suicide are higher compared to women. Maybe there's a lot more poisoning in women compared to men. So and that's deemed to be a bit less lethal means. So it's a method, but the primary thing is really about that health-seeking behavior. It differs men versus women. There's the aspect of culture and how, especially in Africa, how our men are cultured to think that they, maybe seeking help, especially for mental health conditions, is a sign of weakness in some ways and things like that. So that wrong, belief that, the way we are cultured makes them makes them hesitate to actually seek out help. So again, even in our advocacy efforts, when we're creating awareness, that is really a big target, that it's okay not to be okay. It's okay to share. It's okay to reach out to someone when you're feeling like this. And it's not a sign of weakness, and anyone can be going through this. There's nothing specific about being male or being female or being a teacher or a doctor or any kind of profession. Anyone can have these feelings, and it's important for them to reach out and seek care. So those are some of the main issues around the differences seen between men and women. Back to you, Dr. Paris.
Yeah, thank you, Doc. Is it true that male homosexuals commit suicide more?
Well, when you say more, again, that means we are comparing. I don't know the comparator is what, but what is very true is that people, we do have special populations that go through a lot more traumatic events. They suffer a lot of trauma, again, really linked to the stigma and the discrimination. And this really contributes to depression levels, contributes to post-traumatic stress disorder among these special populations. So at the end of the day, you might find, because these persons they have higher rates of trauma, they have higher rates of depression. Maybe they're trying to cope with using substances. All these are risk factors for suicide. So the more they're there, the higher the risk of suicide. So it is true that even interventions really need interventions, especially that are working with the special populations. They can really put in measures to do with suicide prevention as well. Thank you.
Okay, thank you. So what's your take on someone who wants to quote unquote vanish what's normally referred to as pseudocide in relation to the topic of today?
Sorry, I didn't get the last part. Can you repeat?
Yeah, what's your take on someone who wants to quote unquote vanish what's normally referred to as pseudocide in relation to the topic of today?
Vanish. That's it's okay. It's not very clear to me, but again, I just keep reiterating. Let's try, and even among ourselves, we need to be able to reach out and really seek help, even within our own social support systems, to reach out and see who is your social support system, being able for the person to be able to understand who can they reach out to, who can they open up to, because the idea of I don't want to be there, I don't want to be part of this world, it means there's a level of distress that is going on. So being able to share with someone, being able to understand why, what is going on that would make you want to think like that. So the care seeking is extremely important, and just reach out. And if someone reaches out to you as a person, it's important that you also link them to specialist care so that they can get the care that they need. And just being able to talk about it is to listen to them and to be able to talk, that it's not something that is so hidden or stigmatized is extremely important. I don't know if I've answered the question, but for me, I would really emphasize on that aspect of people feeling comfortable to reach out to their own support systems, whoever they think that support system is, and be able to gain linkage to care, specialized care that can support them.
Yeah, thank you, Doc. There's a comment here, or rather it's also a question. According to the current economic constraints, the male child is prone to commit suicides. How is the Ministry of Health, how is the Ministry of Health planning to assist the male species, because something ought to be done as a measure?
Okay. All right. Yeah, so there are aspects of I can see where they're coming from in terms of in fact, we were just talking about this determinants of health, and economics is such a big issue right now, even in our country right now, and also globally, to be honest. So even if we put in interventions, even if we put in like healthcare workers who are able to address issues to do with suicidal attempts or suicidal thoughts and things like that, at the end of the day, we still have to keep talking to various agencies. And as Ministry of Health, we don't work on our own. We work together with the finance aspects of the ministries of finance. We work with Interior. We work with several other organizations just to be able to try and say it's not just the mental health issue can be contributed by all these other determinants, all these other factors. So we work closely with these other teams, and just recently we even launched the investment, the mental health investment case, just to show the government, and this is from the finance or the treasury perspective, in resources for managing mental health conditions, or if you put in resources that address this, or if you address the economic aspects that contribute to mental health conditions, how much saving will you be doing at the end of the day? So we know it's not something that we are doing just on our own. And yes, these conditions do have an impact. And I think the biggest thing is really trying to work together with the various ministries. And for the Ministry of Health is really ensuring that the access to care is available, even as we advise the governments on the repercussions of certain elements on the economy and the mental well-being of Kenyans. So we do have a lot of collaborative engagements with other ministries to be able to support fully. Still, the access to care, I think, is still a priority, even for these individuals. Thank you. I don't know, maybe Dr. Paris, you're also in the Ministry of Health. You can add on to that.
Yeah, thank you, Doc. I think you have comprehensively talked about it, because this one is aligned to the mental health investment case that you have alluded to, because it's looking at if some of these issues are, noted earlier, and people are given preventive measures supported by the government, then what are the gains that we get from it? So really, I think we'll do a lot more advocacy, so that then even the government can take up, financing for these preventive measures, so that then we do not have, as quote unquote say, the male species who are feeling like they are very disadvantaged. So then we can have preventive services that are geared towards them, and they're able to be reached much earlier before they get to the level of dying by suicide. There's a question on how best can one advise suicidal patients to change their minds?
How can someone just repeat the question?
How can someone advise suicidal patients to change their mind?
Well, okay, there's a whole intervention around persons who come in crisis level. There's a crisis intervention for suicidal persons when they come into care. So I think maybe even that can be something that we even discuss in a lot more details. But I have to reiterate, the most critical thing, even in that crisis intervention, is about listening. So it's not telling them that, oh, it's a sin, or, that's not even a big problem. There are people with big problems. We really need to move away from that, because everyone's problem is really justifiable. Is to be able to lend them a listening, like what really is going on. I'm just here. I'm here to support you, and I'm always here. If you feel a certain way, if you feel like you're thinking these thoughts, please just come to me. I'm available, and I'm here to listen to you. And being able to provide now that linkage to care. I'll just keep emphasizing that, to specialized care, because there are people who that's what they've actually been trained in managing, in being able to address issues to do with the suicidal crisis. So I think, if we are speaking from just someone who's not from a non-specialist, I think the most important thing is really listening. The other thing is building on their sense of hope, because by the time someone is feeling like, they're tired of life, life is not worth living, there's a sense of hopelessness. So trying to understand, what does this person have that can give them hope? What do they have to keep going? What are the things that can motivate them to keep going? What's working for them? And this you can only pick when you actually listen to the individual. And yeah, I think that whole aspect of listening is still the the most overall, the most critical part. And not being able to to be judgy, or to put them down, or to diminish their reasons as to why they're having the feelings that they're having. Just to listen and to be supportive, and also to link them up to care. Sometimes it's also part of the crisis intervention is to be able to find out who is their support system, and they can actually name these people and say, I usually talk to this person and this person. So as a clinician, you say, so whenever you have these thoughts, why please reach out to this person you've said that you usually talk to, so that they feel like they're not alone, and that there's hope. There's hope for them to get better. There's hope for whatever crisis they're going through, for them to ride through that crisis and still come out strong at the end of the day. Yeah, back to you, Dr. Paris.
Yeah, thank you, Doc. As we wind up, thank you. As we wind up, we'll take two questions because we are moving past our time. So the first question is, if the medical professionals cannot tag a patient as having suicidal ideation, how do you manage the case during and after the patient has been discharged from the hospital?
Mm-hmm. So again, as I said, there's a lot of like about 90% of patients who attempt suicide still have a diagnosable mental condition. So the management, if they're managing for depression, it's actually the correct management in this case. One of the symptoms of depression is having suicidal ideation. So being able to treat the depression is actually very key. It's the underlying thing. They are being able to traumatic events. If the person has, let's say, post-traumatic stress disorder, being able to treat that is extremely important in managing now the symptoms of suicidal behavior. So like suicidal attempts and suicidal thoughts. So I think at the end of the day, it's critical to have that underlying disorder, if there is a disorder, for it to be managed, and that's what usually happens. But it's not just like it should not be talked about. We still have to provide some support system addressing the suicidal thoughts, addressing where they can get help, addressing who they'll be contact person when they start feeling suicidal again, who can they talk to. what can they do to still, gain some level of, breaking away from now that crisis moment. What can they do at that particular moment to sort of distract them at that particular moment, and who can they reach out to? Back to you, Dr. Paris.
Yeah, thank you, Doc. The last question is there any link between suicide and borderline personality disorder?
Yes, there is. Persons with borderline personality disorder have a higher risk of attempting suicide or dying of suicide. And some of the symptoms that are related to borderline personality disorder is what actually predisposes them to a higher risk of suicide. The depression is higher among persons with borderline personality disorders. The way the decision making is a lot, faster, or sometimes it may not be, they don't take that much time they make very quick decisions. And just being the way they, it's more of a reactive kind of personality. And that also predisposes them. The issues around substance use are also higher among persons with borderline personality disorder. And that, the need to feel, supported or loved, or if they don't get that feeling, if not reciprocated, there's a lot of reactive kind of behavior, and you find those persons would threaten to attempt suicide a lot more. So there is therapy for personality disorders. There's psychotherapy, dialectical behavior therapy for making them be able to understand what is going on, why they are the way they are, and what they can do to identify some of these features that contribute to that personality disorder. So there is help. They can just seek specialized care from a psychologist, a psychotherapist to manage the condition. Back to you, Dr. Paris.
Yeah, thank you very much, Doc. Thank you very much, Doc. I can see participants are very grateful for the very elaborate presentation that you have done this afternoon. Kirui, we can see your question, but because of time and many other questions, we will respond much later. We can see one of the participants saying, Mwiti, you're saying kudos for the insightful presentation and elaborate discussions. Thank you very much. And the comments are very many, Dr. for the very enlightening session you have given us this afternoon. We really appreciate your efforts and time to make sure that we are well, well educated on matters suicide surveillance. For the participants, thank you for your time. For the past 1.5 hours, you have given us all your attention. We really are grateful, and we wish you a very wonderful afternoon. Thank you and bye.
Thank you. Thank you for your attention. Thank you. Bye-bye.